everyone to our first class of integrated patient care. I see we just got connected within the last minute, but I'm wondering, you guys in Augusta, Savannah, and Albany, can you see our screen?
No.
No. Okay. Is that no for everyone? Oh, here comes our help.
Albany can see it now.
Okay.
You figured it out?
Did I?
Yeah.
Is that the correct one?
So I get it. I'm sharing it out. Stop sharing it right now.
Okay.
So they're gonna say something. So we're gonna share, and then you just choose the piece.
That's what I thought.
Yeah, it makes sense.
Okay.
A lot of people just spend on this information.
Okay.
This right there too, so you can see it a little better.
Okay.
You just touch that layout
And
kind of shift it around. And you can kind of change it around whatever works best for you.
in this first part, we're just going to talk about class, and so it's something we could get the student of the other campuses up here, but then later we'd like it to.
So what you gotta do is just go from this view.
Okay. Okay.
So
Perfect.
then just hit desktop.
Okay. Okay.
So if you want that to be a little larger, you can do like that.
Okay. Okay, perfect. One more question. When I use the doc, can I just go over here? Yep. Right? Okay. 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 Okay.
So right here, there's
You'll be
a
a private semester, right?
Okay.
that, you'll notice it's kind of swimming back and forth. And the reason is just because otherwise that paper
I know.
see it doesn't go back and forth. Because otherwise it goes back and forth.
Me too. Yeah. Okay. Okay. All right. Okay. All right. I think we have that. Okay. All right. Okay. I think we're all set up now. Again, welcome. I hope everyone knows me by now, Beth Phillips, and I want to introduce you to our team. So in Augusta, we have Dr. Andrea Newsom. In Savannah, we have Dr. Chris Bland, and in Albany, we have Dr. Daniel Chastain. Between the four of us, we are the ones that kind of run, administer, have designed, updated the course, and we spent a lot of time. It's really been probably 3 years. This course has been 3 years in the making. Last year was the first year we taught it to the entire cohort of the P3 class. And we learned a lot from that class, and we made several updates to the course. And what we want to do today is talk a little bit about what the course is all about and what you're going to be doing this semester and our expectations. And then we are going to go over an example case together this first week of class. So I would just like to open it up to the coordinators for a second to say hi to everyone. Chris, you want to go first?
Left the room.
Oh, okay. Okay, perfect. All right, Dr. Newsom, do you want to say hi?
Hello. Looking forward to hanging out with you guys for 2 sessions.
All right. Sorry.
You want me to go over my first, or we can go to Bland?
Just 1 second. And then Dr. Chastain, do you want to say hello?
He isn't here.
Hopefully I'll get here pretty soon. Okay. All right. So, as promised, what we wanted to talk a little bit about is what the course is and what it's all about, and then each of us is going to tell you a little bit about the course in particular. So this is called Integrated Patient Care, but probably a better name is Integrated Patient Cases. So this is a skills-based, case-based course. It's also, some people refer to it as a capstone course, and that's a term that we use in academia, which essentially means that there's not really going to be any new knowledge taught in the course, but we are going to try to really hone in on all of the things that you've been learning thus far in the curriculum with the goal of getting you guys ready for your APPEs and beyond and for practice. So each week you're going to have a new case, and we're going to be using EHR Go, and you guys are very familiar with EHR Go, right? From recitation and from EPP, or not essentials, APP last semester. And so we're going to simulate clinical practice as much as possible using that EHR and real patient cases from our practice sites. And so the goal here is that we are going to develop your patient workup skills. So when you go on APPEs and you get assigned your patients, you are going to have to take a look at them and really evaluate your drug therapy. And so we are going to be practicing this on a number of different cases. And these are going to be more complex cases than what you've studied in pharmacotherapy. So in pharmacotherapy, we've really been talking about cases in the context of the disease state that you are studying. But in this course, you're going to have patient cases with a number of different disease states, and so we're going to be evaluating all of those with respect to their drug therapy, just like you would on your APPEs. And so that's how this course is going to be a little bit different. And then just briefly, I'll just mention, and we'll go into a little bit more detail later. So each week will be a new case, and so that case will be available for you to work up about 1 week in advance. And every week you're going to have a quiz on the material at the beginning of class. And so today we'll have a practice quiz. Next week, Dr. Newsom is going to have another example case, so you'll get to practice doing it yourselves. And then after that, it will be the every weekly case. And then for assessment, we will have 2 practical examinations. And I'll go over that in just a little bit in more detail. But before I go any farther, I want to just turn it over to Dr. Newsom to tell you a little bit more about the course as well.
Awesome. So this is an awesome course for you guys. You may not like it a ton while you're in it, but you are going to be very happy that you took it by the end of it. You're going to go into rotations and feel so much better than you do right now. This is a course that I know that I wish I had had during when I was coming through. So I hope that it is a lot of fun for you guys, and I'm looking forward to doing it with you. So a couple of things is, what is a complex case? Let's talk about that. Hopefully you guys can see my slides coming through.
No, actually we can't. Let me see. Can you press send presentation? Oh, actually, stop sharing. Okay, now maybe we might be able to.
How's that? I can see it on my end.
No, we can't see it yet.
Oh, this looks like interesting.
I don't think it's you. Yeah, I think the microphone in
Uh-huh.
Athens is causing it to echo.
Gotcha. Do you think you guys would mind turning off your microphone in Athens for a little bit? We have a pretty big echo, and I'm going to grab Mr. Ronald on our end so we can see this PowerPoint.
Listen, Courtney texted me and she said, we can't hear her well, she's breaking up. Oh well, this is exactly what the pinning ceremony is going to sound like.
Oh my God.
I thought that was so funny.
Okay, now we can see it.
Oh, you guys can see it now?
Take their class.
So all campuses can see where it says, what is a complex case?
Yes, in Athens.
Savannah, Albany?
We can see it in Albany.
Which campus is making all that, all this background noise?
Always that. Always that.
Dr. Phillips, would you mind turning your microphone off?
Always that.
Seriously, give me the chase.
Our grade
Okay, so what is a complex patient case? So a complex patient actually the real world. So in pharmacotherapy, when I come up and teach, and you know that I'm going to be teaching about end-stage renal disease, shockingly the patient in your case is going to also have end-stage renal disease, right? So it's pretty easy for you to know what you're going to be doing. Whereas in real life, what happens is you get a patient and you don't know what's wrong entirely, and they have end-stage renal disease in the context of like 5 other disease states. And so this makes life much more interesting for us. So now you have a patient who, let's say, they have heart failure, and we all feel really good that we're going to give ACE inhibitors for heart failure, but oh, by the way, they have an AKI. That is real life. So now the question is, do you give them an ACE inhibitor? Do you put a checking box for later? That is more what a complex case is. So these cases are going to be patients that have multiple disease states happening all at once, and they're going to have a lot of different things happening with their pharmacotherapy, and you're going to have to decide what you think makes the most sense for that patient in that moment. And by the way, you're not going to necessarily know what the primary problems are. You probably can start to guess that probably Dr. Bland's going to have an ID themed topic. I'm probably going to have some cardiology theme, but you're not exactly going to know. So I think to me the biggest differences is the multiple disease states that are happening at once. The fact that you don't entirely know what's going on with the patient, and that's part of the process for you, is trying to figure out what are the biggest issues, and kind of coming in more like real life, basically. In terms of working a patient up, there's a form that you guys can use as a little patient case workup form, and that will be a helpful thing to kind of organize your thoughts. You know, generally speaking, how the exams will work, how we're going to structure the whole class is you're going to have to pick the biggest medication-related problem that the patient has and explain what it is, why they have the problem, what you want to do about it, and what kind of follow-up or monitoring you're going to do as a result of that. And then you're going to go through and you're going to find the next biggest problem and the next biggest problem, and so forth as you go. One of the things that's going to be very important for this class is the use of applicable guidelines and information with regards to that. So if you notice that your patient has a primary problem that seems to be focusing around atrial fibrillation, it would follow that you would want to pull up the AFib guidelines to look at those, because we're going to be expecting that that's going to be part of that's going to be part of discussion in class. It's also going to be kind of what the quizzes are about, is kind of like, are you able to look at a case and pick out the major things that are going on, and do you have a basic understanding of the disease state that that patient probably has as a result of the workup. All right. You know, key things I think for every one of the classes is going to be, please run our drug-drug interaction checker. Please look at the dose, make sure the dose makes sense, you know, kind of basic pharmacy stuff. Match medications to indications, that kind of thing. I also want to go through kind of, you know, last year was our first year teaching it, and so we had some kind of, you know, interesting hiccups along the way, both on our end and the students' end. So these are kind of some of the more humorous comments, but I hope that they will make an impression upon you in a way of how to be successful in this course. So one of the ones was the lowest grade on the Augusta campus last year, which was a single digit. He came to me later and said, I just didn't realize that you had to click on the chart to see stuff. So please realize that the whole class is based out of Near Perfect and EHR Go. You definitely need to become competent with using the chart. If you're finding that you are struggling with using the chart, that is going to be a problem. Find a friend, come to your faculty mentor, find somebody to work with that. You will not do well on the exam if you cannot use the chart, okay? It doesn't matter what you know. If you can't click on it, it's not going to go well. I thought that insulin order mistake was just a typo. That's the whole point of this class, is in fact to identify typos and to bring them up for discussion. I will tell you that occasionally it is just straight a typo, and you will be like, hey, Dr. Newsom, this is happening. I'm like, no, it's not. And then I'm like, oh, indeed it is. That's, if ever you're between typo or not typo, always go with that. We put it there on purpose. And if you find an extra thing, we'll give you a gold star or something. So please, if you think that it's a typo, that's like your job as a pharmacist, is to identify typos, and that is real life. So again, please go with the fact that it was put there purposefully and write it down. I didn't put all the drugs into the interaction checker. Key issue here, okay? Like drug-drug interaction checking is a major pharmacy role, so it's going to be very hard for you to do well if you don't put all the medications the patient is on into the checker, all right? I know this may seem obvious, but we had several people that said this, so just, you know, put them all in there. That's very helpful. I didn't know what to talk about first. This is kind of the point of the whole class, is to learn how to prioritize. I will expect that it will be hard the first few times of what to talk about first, but that is really the goal of this whole class, is to learn how to prioritize. Generally speaking, when we're looking at it, we're going to kind of try to identify like the biggest problem where we all kind of agree this is the big deal. And then it kind of gets a little bit harder to say what's the second biggest problem and the third biggest problem. And so we're not going to ask you to rank. It's basically number one and then everything else. All right. So if you find that you're 3-4 cases in, you're still struggling with this, again, please reach out for help. I just kind of panic and start randomly clicking things at the last 5 minutes. This is kind of like a strategy for when you're doing your exam. So you're going to have 20 minutes to work up the patient. Please don't panic. So you need to develop a system of how you're going to work them up. So Dr. Phillips today and me next week, we're going to spend a lot of time talking about systems. Everyone should come up with their own system for what makes the most sense for them. Please don't have 5 minutes of panicking be part of that process for you. Okay? So figuring out a way to systematically go through this is very important. And I will tell you that panic is never a good thing. Okay. Just read an interesting book actually about the upside of stress. It actually said that the stress hormones, cortisol, DHEA, all of that, when you have those, it actually can help you focus and you can perform better, and it can make you do overall better. And so what they said is that you need to think of it as when you feel nervous, it's actually a good thing. And you should be like, I'm nervous because I want to do well my case, because I want to be a good pharmacist and take care of the patient. Those are good things, so don't panic. I thought if I did well in the quiz, I didn't have to stay for class. This is very much not true. Okay, the quiz is only to make sure that you did the pre-work, because you will get nothing out of class if you don't work up the patient case. So classes, if you had to pick one class to do the pre-work for, this would be the one this year, in my opinion. All right. So please do the work beforehand. Ideally, I think you want to try to get faster over time with working up the patient. Maybe time yourself. See what you can get in the first 20 minutes, like you're doing the exam, and then spend the rest of the time kind of figuring out what you want to do. Please stay for class. It's going to be very hard to improve your system, your critical thinking skills, if you get a quiz. I didn't have a weight, so I didn't calculate a crowding clearance, and I didn't think I could use EGFR. This to me was just one of the more kind of bizarre moments. This is, again, I want you to be thinking from a patient perspective, from a clinical perspective, in that just because maybe you don't have the exact piece of information doesn't mean that you can't maybe make an educated guess as to what's going on with the patient. So if I tell you that the patient had a serum creatinine of 1 yesterday and it's now 4 today, I don't think it matters if they weigh 80 kilos or 90 kilos. You probably know something's not right, okay? So again, take a step back, big picture, okay? With that, very excited for all of you to take the course. I'll be here for you, whatever I can do, and I'll turn it over to Dr. Phillips.
Everyone hear me okay on the other campuses?
Yes, please, Dr. Bland.
Yeah. Okay, awesome. So welcome back. I haven't been able to tell you guys so far. As what's been said, I really like this course because it really, all the coordinators, we want you to be better prepared for that first rotation that you're going to step foot in next year. And I've got one of my residents here with me, and talking about that first rotation can be kind of a scary thing at first. And so a lot of this class is really geared towards helping that angst go away. So I think what you want to know as a student is, all right, what do I have to do each week? Like, what am I really responsible for? So cases are going to be available 1 week prior to class, okay? So during that week, you will have that time to work up that patient. And that term, work up, really is, you're going to see that a lot over the next day and then next week, kind of what that means. Because when you hear that term, I know a lot of times it's kind of a weird term. But it's really digging into the electronic health record and finding out what is pertinent about that patient specific to their drug-related problem. And so throughout the year, the best thing you're going to do is repetition. Repetition over and over again. You can do it in an individual setting, on your own. You can do it as a group. Obviously, you're sitting in your groups, and that's great. We expect you to know everything on an individual basis. So it's not going to be uncommon to call on you as a person, okay, as opposed to just, okay, group 25 here in Savannah, tell me what you think. And you all kind of look at each other, and then, all right, who's going to talk? At this point, we're going to be, you're going to be on rotations in 4 months, right? When you think about that, it's coming very quickly. And so to be able to stand on your own 2 feet and to be able to confidently give drug-related problems and their solutions, I think is really important. That's what this class is for. We'll have a quiz at the start of every class. every class. We'll talk about that in a second. Again, you can discuss those cases with your fellow students. Again, we're trying to simulate what happens in practice, okay? Dr. Matson here, one of our grads and one of our current residents, she and I spent an hour going over patients this morning, right? And there are some cases that are hard. And so it's not a problem. It's actually good to talk with other students to kind of get their perspective. You can talk with me or whoever your campus coordinator is if you have a question about, because we want that. We want you to get in, be excited, and really ask the difficult questions. So some things within these cases are going to be purposefully vague. It's not because we're trying to trick you. It's because guess how practice is? Very vague at times. And it's hard. I mean, right before we walked in here, right, Hannah, we talked about a case and how do we shift this dose, and so that's part of it, okay? So each of you needs to contribute individually to identify disease states, drug-related problems, prioritize those problems, and then develop a potential plan, right? So, if somebody comes in with, septic shock and a DVT, and then, oh, by the way, they have toenail fungus, I would hope toenail fungus would not be the primary problem, right? Now, for the patient, it might be once they wake up from their sepsis, okay? But the point is to get you in the mindset of really identifying, especially that problem that brought them to that setting or within that clinic setting. We'll have cases from both inpatient and ambulatory care settings. So if you want feedback on your workup form, right, you're going to see, please come talk to me here in Savannah, talk to others in Augusta, Albany, and Athens. We can help you with that. Like I said, there's a quiz every week at the beginning of class. It's going to be an exam solve. So your job each week is to download that quiz, similar to what you do for exams. Prior to class, have it done. There are no paper copies. Okay, there's not paper copies. We'll talk about that in a little bit. As you can see, there's 3 drops available for you with quizzes, and we as faculty respect the fact and have dealt with the fact that sometimes there are technological issues, and so we do not want you to be punished for that, and so that's why instead of having 2, like we did last year, we're having 3. Okay, so sometimes there may be, we had some last semester, I know, with a few students. It's usually not more than 1 time a semester. But we will have that available. So ExamSoft, download those. It'll be a time quiz. We respect your time as students, and we respect the faculty's time that's put a lot of work into these cases. And so we have to really have a time quiz and no extra time for coming in late. So be sure when you get here, your quiz is downloaded, you're ready to go. Student groups are listed in the syllabus. We'd like you to sit in your groups each week. And again, you get to know each other. You should know each other incredibly well by now. But again, kind of this last burst of classroom time is really geared towards getting you prepared for rotations and ultimately clinical practice. Practical exams. We'll definitely talk about these more as the semester goes on. Obviously, these are a big part of the course. Think of it like an appointment, right? In the sense that we have to grade each of you individually. And so on those days of the practicals, you will have a time that you will be scheduled to do that practical. You'll have a time where you go into generally a separate room and you work up that case, 20 minutes, and then you will present that case in the prioritized problem list to somebody on that respective campus. For like Savannah here, it's obviously going to be me with other faculty or a resident. And so you'll present that. So again, we're going to give you, one of the things we learned from last year to this year is we don't feel like the students had a good appreciation for what that looks like. And so we're going to have practice time to see what that looks like, as well as seeing it in action. And so that you can say, okay, that's what presenting a good patient workup looks like. Okay? The grade breakdown is listed there in the syllabus. 30% quizzes, 10% participation, and then 30% each for the midterm and the final practical. That's what we just discussed there. So again, we're very open to questions throughout. I know that this is different than what you're used to. Instead of just logging into a computer and taking an exam, this is more kind of a different set of skills. Instead of you being the expert of AFib and every journal article there is, that's part of it. But a lot of it is, how do I practically abstract the medical record, find the pertinent information, assess all of that information, and come up with a plan. Because that's what you're going to be doing every day on rotations when you have those, especially in the clinic settings and then the inpatient settings. And then ultimately as a pharmacist, that's what we're constantly doing all the time. So this is for your benefit. I know there's a little bit of angst and anxiety about presenting, but that's why we practice with each other. That's another thing you can do that I think is very helpful. So, as we say in the government, we're here to help, and just not while we're furloughed. But anyway, so with that, we'll have much more time for that. We'll approach that a little bit different, or a little bit more detail when we get to it. But Beth, I think at this point I'll hand it over to you.
Can everyone hear me? Yes, and I turned my microphone off because Augusta was getting feedback. Are you guys okay? Okay, perfect. Okay, so, Dr. Chastain, I don't know if he made it to class, if he wants to add anything. He just joined our group as coordinating. Dr. Fong was the coordinator for, since the inception of the course, but as we know, she left us for family reasons, so now we're excited to have Dr. Chastain join us. So as we all mentioned, we're all part of the coordinator group and we're all here to help you. I just want to go into a few more details about some of the things that we brought up. One in particular is Dr. Newsom alluded to the fact of what student comments we received last year. And overwhelmingly, we did get a lot of feedback from students, as you can imagine, and we have systematically gone through and made some updates to the course in hopes of better supporting your learning, and I'll try to point those out for you in just a moment, several of the things. But by and large, when you look at it as a whole, the students really felt like they learned a lot in terms of how to work up patients, and several students have even kind of come up to us now that they're on APPEs and said that even their preceptors have seen a difference in terms of how they were able to work up patients and how prepared they were for APPEs. And that's exactly what we're trying to do. But we learned a lot from last year, and so we're going to incorporate some of these things as well for this year. To give you a little bit more detail, I'm going to go over the class schedule in just a minute. But the quizzes. So we've alluded to the fact that there are quizzes every week that will be on ExamSoft. So that was the message on Friday to go ahead and download. We have a practice one today that we will take after we work up the case together, so you'll get an idea. But to tell you about the quizzes, that was one of the things that we've updated in the course for this year. We have asked all of the faculty to update and develop new quiz questions that specifically are related to the workup of the patient. So all of the questions we've asked will refer back to the patient case. We will not be asking you to memorize certain things, like what was the potassium level or things like that, but if the potassium was low or if it was high and that's a drug-related problem, then we would have expected you to identify that, and you may be asked a question related to that. And so there also was a little bit of a misperception among some students last year, as Dr. Newsom alluded to, that if they aced the quiz, that they knew everything on the case and they really didn't need to participate in the discussion. So the quizzes specifically are going to ask about the patient workup, but we're not going to ask you to give us a detailed assessment of those drug-related problems, like the deep dive that we're going to do in class, and we're not necessarily going to have you tell us what the big plan is. That detailed discussion, assessment, rationale, and the plan, what's the best thing to do, is what we're going to discuss in class. And those are the types of things you're going to need to be able to do well on the practical exams. So the purpose of the quizzes, one, is to help you guys prepare for the cases, but also to give you some practice in identifying some of those drug-related problems specifically. So each of those questions will refer back to the case, and as I mentioned, we're going to go through practice one today, and we're going to have a practice one next week. And also, as we mentioned, new this year, we have a patient workup form for you guys to use. So we would encourage you to use that every week. And when you come in for the practical exam, you will have a blank one of these worksheets, and that will be your scratch paper, if you will, that you can use to work up patients. So we hope that by using it every week, you will feel really comfortable with it in a practical situation. So as Dr. Newsom alluded to as well, we're really trying to teach you the steps of working up a patient using the pharmacist patient care process. You guys probably can repeat it in your sleep. But we want you to develop, we want it to be second nature to you. And sometimes during the practical last year, the students came in and they kind of forgot everything that they did, and they panicked a little bit and then just started looking all over for bits of information. And that's not what we want to happen. So we're going to really try to help you develop that systematic process. So part of that is giving you the workup form, and specifically with the way the quizzes are structured. Let's see. And questions about that? Okay. So I wanted to go over the class schedule with you. So class, I think it's listed in your schedule booklet, is meeting on Mondays and Fridays. It is a 2-hour class, and so most of your 2-hour class is going to take place on Mondays. But because we meet mostly once a week, and because of some scheduling things, sometimes class will meet on Friday. And so I tried in the syllabus on ELC, I tried to highlight anything that's different in a regular schedule. So for example, next week we have a Martin Luther King holiday, so we won't meet. So instead, we're going to have class on Friday instead, and the class time will be 11:15 to 1:10. So just make a note of that. We'll try to remind you about that each week, but you guys are responsible for knowing class each week. And then another thing that we implemented this year from last year is we have 2 exam practice sessions. And so this was so that you guys could actually practice some cases like what will be on the practical, and you'll have a chance to do it in small groups and get some feedback. So we are doing that on February 15th, and we're also doing it on April 12th. So you can see that we have the group numbers and the locations already assigned. Augusta, we have a conflict with groups 19 and 20, so we're going to find someone, so that's why you don't have someone listed yet, but we will have someone by February 15th. And so we're going to simulate the practical environment as much as possible, but we're going to give you guys a chance to kind of individually practice kind of presenting the problems and things like that. And let's see, so that is on Friday, and then these 2 exam practice sessions on Friday, and then at the end of the semester on April 19th, that class is on Friday as well, patient case number 10, and that's going to meet from 12:10 to 2:05. And then, so we will have 2 practical examinations. So we'll have a midterm practical and a final practical, and so those will be on Mondays. We have PS 101 and the skills lab reserved, and that's going to be from 12:20 to 3:20. But we will have more specific information when it gets a little bit closer to the time. A couple of things. So we just mentioned about the quizzes. We do have 3 dropped quizzes, and because of the nature of the quizzes and needing to be present in class to be able to discuss it, we won't have any makeup quizzes. But if you do have to miss class for any reason, illness or death of an immediate family member or something like that, if you would send your documentation to us, we will collect that, and then if we need to revisit that at any time during the semester, then you'll have that information. We'll have it. The other thing is, if you do experience technology issues, we would just ask that you take a screenshot of it and just email us in real time that you're having those issues. Again, so we can try to help you with that as well. With ExamSoft, the reason why we switched from Respondus Lockdown Browser to ExamSoft is that ExamSoft is a supported software. So if you do have issues, you can contact an ExamSoft technician after class, and they should be able to get you back up and running. But from what I understand, about 95% of the issues are resolved when you reboot your computer. So we're going to try using ExamSoft this semester. And then, let's see. So midterm and practical, so after April 22nd, you guys are going to be done with class, so you'll be done a little bit early, so that should be good news to you as well. And for the quizzes, we are going to have the quizzes proctored as much as possible. We'll have different people in different locations, but I do just want to let you guys know that we are, just to try and keep things consistent across all the campuses, we are going to have the rooms recorded with the cameras during the quiz time. So just so you're aware of that. And let's see. As I mentioned, also, one of the things that we did differently this year is that we have made some videos for you guys to watch. That will help you kind of modeling the patient workup, and we have one this week, and we have a special assignment related to that, which I'll talk about a little bit later. And we also have a modeling video of how we would expect you to present the patient. And then for each of the exam practice sessions, we'll have a video modeling. It's usually a PGY2 resident who's modeling the patient presentation. So you'll be able to see how that all works and what that looks like. So we hope that will be helpful as well. Let's see. Any questions about any of that? Okay. So we have a couple of things that we would like to do. The first one is if you go to ELC, we actually have our first assignment, which is the Learning Outcomes Assessment. So if you guys could go to your computers and go to quizzes and go to the Learning Outcomes Assessment, we would like to take a baseline of kind of your self-rate of your abilities, of how comfortable you feel working on complex patient cases. So if you go ahead and just take a few minutes just to take that, it's in there as a quiz right now, and you'll get participation points for that Learning Outcomes Assessment. So does everyone see it? You go to Tools, or you should be able just to click on the quiz, right? you raise your hand if you're still working? Okay, so is everyone pretty well done? All right, so we're going to go ahead and go through our practice case for today, and it's Charlie Moore. So it looks like everyone, at least in Athens, has their computers open. And this is, we're going to go through this together and we're going to practice, but this is something that you guys are going to have to decide what's the best way that you learn and what works best for you. So each week we will have this patient case workup form available on the cases. So you may want to split screen and kind of fill things in on your computer if you like typing, or you may want to bring a blank or your worked up patient that you've already filled out, like in pencil or pen or whatever, and make notes on it that way. So, just decide how you best want to learn. But I've got the workup form that I completed, just to kind of show you a few things. And then one of the things that we've asked the faculty to do as well is to develop their own guide of how they want to work up the patient case that mirrors what we're asking you guys to do as well. So on your patient workup form on the second page, it asks you to list the drug-related problems along with your assessment, including the rationale for why it's a problem, and then your preliminary plan. So on the faculty side, they are thinking about the subjective and the objective information, which is what you're collecting on the front side, and then they're also doing an assessment and plan for each of the drug-related problems. So they're going to go through that with you kind of systematically. So I'll show you my thought process, and each faculty member may do it a little bit differently, but we're asking them to use the same methods and give you the same information. So we worked really hard to try and present the cases to you in a systematic way so that you'll know what to expect each week, even though the cases will be very different in terms of the disease states that they have. And as we alluded to as well, is that we're going to start off today we'll have a case, and then next week it's going to be a pretty complex case because it will be more critical care related to practice. But then after that, we'll start with ambulatory cases, and then we'll kind of progress in complexity. We'll move on to hospitalized patients, and then we'll kind of end with more critical care and oncology type cases. So that's the progression of the semester. So if you would go ahead and click your link to Mr. Charlie Moore, I've got him up here, and this is what you should see. And I'm going to start a new session.
What? There's two.
Okay. So everyone has their patient workup form, yes? Okay, so one of the first things I like to do when I take a look at a patient and see them for the first time is I like to see what drugs they're on. That gives me a quick idea of some of the things that I'll be seeing, what types of problems they have. And then I like to match those with indication. So with EHR Go, it gives you kind of a face sheet here, as many electronic health records do. But as you probably noticed with EHR Go, there are some little specific things related to the chart, and you have to look here, look there for different things. And you'll find when you are out on your APPEs that every electronic health record has its little quirks and things. So this really kind of gives you a chance to practice kind of knowing where to look for the information. So for me, this face sheet gives me a little bit of information, but I like to go straight to like the medication list or the problem list, because I find on the face sheet with the EHR Go, it doesn't really give you a full problem list, and that can really kind of confuse you. So we've got the medications here, and so this is, so I like to go on my sheet. I like to have the medications listed there and their doses, all right? So I've got it listed there for EHR Go, everything that they have listed. And one of the first things I'll do there is just take a quick check and see if I can see anything related to the dose or route or drug that looks a little bit off to me. So in looking at this medication list, do you see anything that's different, or do you recognize any doses that may not be exactly as you think they should be? Maybe I should flip back to EHR Go because that's kind of small. So this would be the type of thing that as you're kind of working up your patient, we would want you to kind of just check on doses. And so, you know, there's a number of different ways you can do that. But what we want you to do is start developing good habits. So, you know, if Lexicomp is your go-to and you're not familiar with the doses, then you can check there. You know, if it's something like, you know, atorvastatin is one of the first things on the list. If you remember from Dr. Rebich's lipid notes from pharmacotherapy that there's some tables in there with some doses, that might be the fastest thing for you to look at. And in reality, once you get to APPEs and in clinical practice, medications that you see often, you're going to recognize the doses right away. But we know that as a P3, this is something that you're still getting used to. And again, this is another thing that we're trying to do with all of the cases. So I can tell you when I look at this, the dose that looks off to me is Gemfibrozil because it's 600 milligrams and they have a TID. And everyone knows, right, that you can click on the medication and then it gives you more information, like their last fill date, their initial fill. So everyone knows that, right? So with EHR Go, sometimes it's not really clear what you can, when more information exists, but when in doubt, always try to click on something to get more information. So there we have our medication list. So I like to write it on my patient workup form like I showed you, and then I like to go to the problems. And so here's the problem list. And then I like to match up drug with indication. All right, so we have, at the top here, we have several discharge diagnoses. So acute renal failure, hopefully that is resolved since that was from last August. Pneumonia, again, hopefully that is no longer an issue. You can see during hospital he had uncontrolled diabetes, so that likely could be an issue. Again, we certainly want to look at it, and acute cystitis, so hopefully that's not an issue. But then here we have some chronic things. So reflux, osteoarthritis, chronic back pain, hypertension, diabetes, dyslipidemia, coronary artery disease with a cabbage, two-vessel cabbage 15 years ago, and then the patient currently smokes tobacco. All right, so if I go then to my medications, then I'll try and match up. So atorvastatin is probably going to be dyslipidemia, right? Gemfibrozil. Why do you think the patient's on that medication? So oftentimes that's for triglycerides, but you can see I have a question mark there because I want to check that. So I don't have enough information yet to know, right? And then I also mentioned to you that 600 milligrams TID doesn't look right for me. Has anyone looked up the proper dose yet? Not yet? So typically, I'm just going to tell you it's 600 milligrams twice a day. So that's going to be a drug-related problem for me right then and there. And so as Dr. Newsom alluded to, sometimes typos do make their way into the medical record, like maybe if a medical resident was entering it or a nurse was entering it, they may enter it wrong. But nevertheless, it is wrong, and the patient could get the medication TID or whatever, and so it's definitely a drug-related problem that pharmacists need to take care of. Okay, so then we have glipizide, 10 milligrams twice a day. That dose looks okay to me. Diabetes. Metoprolol, hypertension, but also coronary artery disease, right? I mean, that can be helpful, although his CABG was 15 years ago. Lisinopril, hypertension, and also can be beneficial in diabetes, right? So for patients who have diabetes and elevated blood pressure. And then omeprazole for the reflux. Then we also have some inhalers, Advair and albuterol. So did you guys see anything on the problem list that would be an indication for those? Okay, so smoking, which is a risk factor for what? Lung disease, more specifically, right? So, and what kind of lung disease? COPD, right? But does every smoker have COPD? No, right? And pneumonia, yes, the smoking would increase the risk of having kind of some complications in pneumonia, but since that was from August, hopefully that is resolved, right? So I've got question marks there in terms of I want to find out if this patient has an indication for drug therapy. And sometimes patients do have problems that are not listed on the problem list. And so that's how, then as pharmacists, we need to go back and check on that. And then the last medication I have here is acetaminophen. So we have 2 tablets every 8 hours as needed. So this patient has osteoarthritis and chronic back pain. So I'm going to assume that it's related to that. Okay, so if we go back, so just by this first step of getting the medications and looking to see, matching up with the problem list, I already see kind of 1-2 drug-related problems here with the inhalers, and I also see the dose of gemfibrozil, and also I don't know the indication. So I already have 3 potential drug-related problems I want to look into further, okay? So that can be a very efficient way for you to start looking at a patient and know where to go next to go digging. So as you'll see with these charts, there's a lot of information, and some patients, you know, obviously have a lot more information than that in the chart, and so you can really get lost in there. And so that's what we want to help you guys learn, is where kind of to go next and be confident in the information that you're looking at. All right, so next, I tend to go then to see, like, what was this patient's vitals? Okay, so they have this patient, and this was supposed to be an appointment today, but it looks like it was last week. So we're gonna go with that. But so we have a blood pressure of 157/89, heart rate 61, and respiration 16. Is that a problem? I think so. And then 5 minutes later, we have another blood pressure of 148/81. So is that a problem? So that's elevated blood pressure, right? So I'm definitely going to take a look at that on my drug-related problem list. Okay, so I'm going to mark that.
Dr. Phillips?
Yes.
I just had a question while looking at the medications. It doesn't specify on the metoprolol. Are we supposed to assume based on the way that it's prescribed, or what is it?
It doesn't. What doesn't it say? Sorry.
It doesn't say if it's tartrate or succinate, and when you click on it, it doesn't indicate.
That's it. Okay. Oh, yeah. No, that's good. It is supposed to be tartrate. So it looks like maybe that was something that was changed. So yes, it should be tartrate. Thank you. I'll try and edit that as soon as I get a minute. Okay. All right. So now we've identified another thing that can be a drug-related problem, right? Okay. So then we have the gemfibrozil, and so we wanted to look to see if there are any issues with, triglycerides. Why is this patient on it? So let's take a look at his lab values. All right. And so you can see here on EHR Go, you probably know from last semester at the very least that this can be a little bit confusing the way they present the lab results, right? But you can navigate over here to what you're looking for. So if we click on the lipid profile, then it will pull up the most recent lipid profile. So we see an LDL cholesterol of 170 and a triglycerides of 184. So why is this patient taking atorvastatin? So he has heart disease, right? So he's secondary prevention, right? So 170, that seems like that could be a little bit high to me, right? Just saying. I'm just going to think about that. Then the triglycerides of 184. So that's above the reference range of 150, but is that very high? What do you remember from your lipid?
That's my issue.
So typically, we're going to be more concerned about triglycerides if they're above 500. Okay, so 184 doesn't, makes me think, But, that's another thing is I want to see when he was started on Gymfibrazil. But let's take a look at this. Okay, so look, in May of this year, he had triglycerides that were 293. Okay, that's a little bit higher. And then in March, they were 107. And then a year and a half ago, they were 156. Okay, so 293, that's a little bit higher. But let's see, it looks like they were drawn at 9 o'clock at night. What do you know about a lipid panel? When is it supposed to be drawn? Yes, so after at least an 8 to 12 hour fast, right? So do you think he was fasting at 9 p.m.? So probably not. That would be, you can ask the patient, but probably not. So, so that could be one reason why the triglycerides are higher that day. Okay. So if I go back to the medications, and I go to Gymfibrazil. So look, it was actually started on May 8th, which was the same day that triglyceride panel was drawn. And then he filled it less than a month ago. So it looks like he is taking it, started in May. So is that something that you probably would have started Gymfibrazil for? Probably not something that I would want to start it for. And what's another issue with Gymfibrazil? So you guys remember from your lipid lecture, or you can definitely...
Drug interactions?
Yes, drug interaction. What's the drug interaction?
The Gymfibrazil picks up binds to the lipids.
I'm sorry, say that again.
Gymfibrazil binds things up.
Well, it's a little bit different than that, but yes, there is an interaction. So it inhibits the glucuronidation of the statin, and it causes statin levels to rise. And what do you think would happen if your statin levels increase? Increased risk of rhabdomyolysis, right? So we generally do not use those two drugs together. Okay, so that's a significant drug-related problem right there. That's something that I would notice when I'm looking at the medication list. But then I've done a little detective work to see, well, if I take them off Gymfibrazil, is it really needed anyway? Do we need something for triglycerides? And so based on that information, does it look like he needs it? No, probably not, right? So, and then again, one thing to keep in mind with these patient cases is we are focusing on the workup. So you guys are coming up with your assessment and your preliminary plan, but once you go and talk to the patient, or once you go on rounds, you may find additional information that's not in the chart that would change your plan. So this is why your workup sheet says preliminary plan. So this is what your assessment, what your plan is based on your workup, if that makes sense. Okay? All right. And then what do you think about that atorvastatin dose for this patient?
Probably low, but it might be low because of the expected interaction.
Okay. So the dose is low, right? So what would you recommend for a patient with this indication? So I'm hearing 40. So what? So give me your rationale. Why would you say 40 is a better dose? So high intensity statin therapy, right? So this is secondary prevention. So the patient should be on high intensity statin therapy. And if I wasn't sure about that, where could I look? You could go to the lipid guidelines, right? So this is another thing with our cases. We are going to get you guys in the habit of going to look at guidelines for some of the common disease states because we want you to become familiar with it. So here are the 2018 AHA-ACC guidelines, which came out after your lipid lecture last year. So this happened last year to the students with hypertension. We had new hypertension guidelines come out. So you will have to take a look at guidelines and be familiar with things, and certainly people will kind of, your faculty members will kind of point that out to you. There aren't a lot of, there are some changes in the guidelines, but they didn't upend some of the things that we have typically been thinking. So secondary prevention of cardiovascular disease is still high intensity therapy. So if you take a look at this, we have a patient whose age is 73, so he falls here. So you recommend high intensity statin therapy. So the goal then is for an LDL to be decreased by at least 50%, okay? So let's see what we can find in the chart. Okay, so one thing we want to do is take a look at the atorvastatin. So when was it started? It was started possibly, about a year and a half ago or so. And when did he last have it filled? September, okay? So, he's a little bit late on refilling his medication, right? So he may not be taking it. So this suggests that he has some non-adherence to therapy, right? So he may not be taking it consistently. So let's take a look at the labs. So we have this June 2017 start date. Let's go back to our lipid panel. Okay, so his LDL was 170 then, and in May it was 132, March 115. Oh, look at this. Almost a year and a half ago, it was 77. So what does that suggest when the LDL is bouncing around a lot like that and you have inconsistent fill dates? So the patient may not be adherent to therapy, right? So that's one thing. But the guidelines do recommend high-intensity statin therapy for this patient, so that's definitely a drug-related problem, right? That makes sense? All right, so let's take a look. All right, so how about his diabetes? So we have a hemoglobin A1C most recent is 7.6. So what do you think our goal is for that therapy? For diabetes. What do you think our goal A1C is? Okay, so I hear a lot of less than 7%. Some people might make a case for, there is some discussion in the literature that patients over the age of 65 or more elderly patients, you can back off a little bit on the A1C, but that would still be less than 7.5, so you would still be above that. because patients who are older are at a higher risk for hypoglycemia. So this patient is taking, we have glipizide, 10 milligrams twice a day. That's our only diabetes medication. So what do you guys think about that? 73-year-old, elevated A1C, and his treatment is glipizide 10 milligrams twice a day.
High risk for hypoglycemia.
So what would be our first line therapy for someone with diabetes? Metformin. So does this patient, but then that makes me think, well, he's not on it. So does he have a contraindication to it? Right? So what will we be looking for? I'm hearing some mumblings. What would you be looking for? Okay, so serum creatinine, right? Okay, so if we go back to the labs, and so the most recent we have a serum creatinine of 0.9. Okay, so, and let's see, we have an EGFR of 61. So that seems like that would be appropriate. All right. So, and then what do we think about glipizide or sulfonylureas as monotherapy in a patient who's 73? Is that what the guidelines recommend? Typically not, because, yeah, so the risk of hypoglycemia. So metformin would definitely be the way to go. And, you know, since his A1C is in the 7s range, there's a chance that we could get this patient, his diabetes, well controlled with his metformin, all right? So the one thing to think about this is though our most recent A1C is what? From August, right? So we don't really know what it is today, but, you know, regardless, glipizide probably isn't a great choice for this patient, and metformin, you know, likely is the best choice for this patient, so it's probably still a good idea, but we can still get an A1C today, probably, and see what that is. How often would you monitor an A1C? Every 3 months? If they're outside the range, right? But if the patient was well controlled, how often do they recommend? 6 months, right? Okay. So we've discussed, well, we started talking about his hypertension. We didn't finish. Should we go back to hypertension, talk a little bit about that? So we have a blood pressure of 148/81. And what medications is the patient taking? We have lisinopril and metoprolol. So what do you guys think about that?
Yeah, totally see that.
So is
pretty good.
metoprolol a good choice for this patient? So did the guidelines recommend beta blockers as first-line therapy? No. But is this patient taking it as first-line monotherapy? No, because he already has another drug on. So this is something that you'll likely see in clinical practice, is you'll have someone that was started on a beta blocker. I'm guessing that he probably was started on a beta blocker maybe after he had his CABG surgery, or maybe if he had angina at any time. But then he needed at least 2 drugs to control his blood pressure. So as long as they're using another drug along with the beta blocker, and there's a reasonable indication for it, and they're not having side effects, then that would be reasonable to continue, right? So he doesn't have any contraindications that we know of, right? What is his heart rate? Do you remember? 61. And so based on our preliminary assessment, does this patient need an adjustment in his antihypertension drug therapy? Yes, right? Would you increase his metoprolol dose? No. Why?
Drop his heart rate.
Heart rate, right? So you could decrease his heart rate too much, okay? So then our other choice is lisinopril, 10 milligrams every day. So is that something that we could adjust? And what dose would you go to? 20 milligrams, right? So remember, like with ACE inhibitors, we typically double the dose up to 40 for lisinopril, and then after that, it typically doesn't have any better blood pressure lowering effects. So how would we monitor that change then? Is lisinopril a drug that we do lab monitoring for? So what side effects can occur with lisinopril? Cough, okay. Increased potassium, okay, so we probably want to check his potassium. What else? Make sure it doesn't pass out, okay. What about labs? Serum creatinine. Okay, so when we initiate an ACE inhibitor or address therapy, then we typically want to check a potassium and a serum creatinine at a minimum. And so when would you do that? Would you do it 6 months?
2 weeks.
Next week? Two to 4 weeks. All right, whoever said that, very good. So when you're doing laboratory monitoring on an ambulatory patient, so meaning that they're coming into the clinic, you always have to consider for them, they have to come back to get their blood drawn. So you have to consider what's convenient for them. So there typically is going to be a range for monitoring lab values. So typically for an ACE inhibitor, I would say between 1 and 4 weeks. So you can check it again as early as a week to kind of give it a chance to really see the full effects. But probably wouldn't go any longer than 4 weeks if needed. And 2 weeks is a great kind of midpoint range. So you just have to kind of see what works for the patient's schedule. Sometimes patients, if they're young, they're working, and so you have to consider that. This patient is 73, so we're going to assume that the patient's not working. But if he doesn't drive or something like that, he might have to get transportation. So you always want to consider that. Okay. Let's see. Okay, so when we think about drug-related problems, so if you think about kind of those 7 drug-related problems of like dose too high, dose too low, taking a drug for which there is no indication, adverse effects, all of those things. One of the 7 drug-related problems has an indication for drug therapy for which the patient is not receiving drug therapy. So do you see any issues related to that with this patient? So think about this patient's past medical history. And is their appropriate drug therapy matched up with all of those indications? Okay, so just take diabetes. So we've already kind of established that this patient is taking glipizide, and that's probably not the best choice. And we already said that we probably want to initiate metformin for this patient. How would you initiate metformin? What dose would you give them? 500 milligrams, and how many times a day? Okay, I hear once and I hear twice. Why do I hear differences? Well, both are correct, right? Typically, we'll start out 500 milligrams once a day for someone that hasn't taken it before, because what's the main side effect of metformin? Kind of nausea, vomiting, diarrhea, GI upset. So if patients take it with food and they start out with a lower dose, and take 500 milligrams once a day for a week, then oftentimes they can tolerate it better. But then quickly kind of get them up to 500 milligrams twice a day, and then you can go up to there, from there. So then we have hypertension. So we have metoprolol and lisinopril. We've already decided that we need to increase the lisinopril dose, right? Dyslipidemia. So we've established that the atorvastatin dose is too low, and we probably don't need Genfibrazil. All right, how about coronary heart disease, stats post-CABG, not CABS? I see we have a typo there. 15 years ago. So this patient does have coronary artery disease. So is he taking all relevant drug therapy related to that?
Shouldn't he be on aspirin?
Yes, very good. Ding, ding, ding. So aspirin is something that we often overlook because it's available over the counter, right? And so sometimes it's not always on the medication list. I know at my practice that we always go ahead and put it on the medication list because it is such an important drug for someone who's secondary prevention. So yes, that's another drug-related problem. It's not has an indication for which he's not receiving drug therapy. And then we have GERD, so taking omeprazole, and then the inhalers we've already established we need to take a look at that. Okay? Questions so far? All right, so let's take a look at his inhalers. Okay, so this is where we have to take a look at a few things. All right, so we've got this Advair Discus. So let's see, it looks like it was started on 8/11, and let's see. All right, so 8/11, and then we've got albuterol. Okay, so that was filled in August as well. So if we take a look at the notes, so we've established that we don't have anything on the problem list, right? The reason why he's taking it. And then if we go to the overview, we see that the patient was hospitalized 8/9 and then 8/17. So 8/9, he had acute cystitis with uncontrolled diabetes, and then it looks like he was hospitalized maybe a week later, and he had cystitis, diabetes, pneumonia, and acute renal failure. Okay? So that looks like that was all happening about the time that he was started on the inhalers. Okay? So let's take a look at the notes. Okay, so we have from 8/23, that patient walked into the clinic today for rewrites for prescriptions from a recent hospital discharge. He'd been admitted ×2 with all of those things we saw. So he got Augmentin, azithromycin, so hopefully not together. Maybe he got one and then another. Advair and Mucinex. And then the patient has an appointment with me in 1 week. Okay? Then 8:30. So he came in for a post-discharge follow-up. So we have his blood sugars there, self-monitor blood glucose ranging a little bit high. And then we have the review of systems, and we don't see any specific problems there. Then we have his past medical history, his vitals, his blood pressure was elevated even then, his physical exam, and then we have the assessment. So we had a nurse visit in 6 weeks for blood pressure, then they wanted him to come to pharmacotherapy, and that's when he ended up in our clinic. No chest pain, send for PFTs, okay? So the physician doesn't see any diagnosis either for his inhaler, so he wants to send him for PFTs. And then they also did an EKG. So here's his EKG, and what does it show? So you see here it says sinus rhythm, otherwise normal EKG, okay? So does that tell us anything? Do we have any drug-related problems related to that? So it's normal sinus rhythm. Does it have his heart rate?
I'm also
Heart rate 60, okay? So, there's this PQRST. So this is basically a normal EKG. So there's nothing related to his drug therapy that we really need to worry about related to his EKG. So you'll find that there are a lot of things in the chart that they'll order things based on symptoms or drug therapy or whatever, but then you need to evaluate it and determine if you need to do anything further with it. So this EKG is an example of something that you wouldn't need to make a change in your drug therapy because of. And then he finally gets spirometry December 4th. Okay, so what are we looking for on the spirometry? So does the patient have asthma? Not that we're aware of, right? He doesn't have it in his problem list. It would be unusual for him to get diagnosed with asthma at age 73, but what would the spirometry tell us? So if we looked at a pre and post bronchodilator, FEV1, then we could see some reversibility, right? So in this particular case, we don't have a pre and post, we only have a pre. So based on the information we have, we don't have any evidence that the patient has asthma. To see if the patient has COPD, what will we be looking for? So you guys remember from lab test class and COPD, what would the spirometry results look like? So would the patient have a reduced FEV1? Probably. So what is this patient's FEV1? It's 87%, so it's mildly reduced. But there could be a number of reasons for a reduced FEV1. So what are we looking at? What's the issue with COPD? So it's chronic obstruction, right? So they have difficulty with airflow in and out. So when they do spirometry, remember you're looking at how much you can blow out over 6 seconds. So your FEV1 is what? The amount you blow out in the first second, right? And the FVC, forced vital capacity, is the amount you blow out over the 6 seconds of the amount that you were doing spirometry, right? So would you expect that ratio to be increased, normal, or decreased in patients with COPD? So probably decreased, right? Because they can't get the air out. So what's a normal value? What are you looking for decreased in a patient with COPD? So you guys remember, are you kind of getting back to the cobwebs of your brain? Where would you look? The more important thing is, where would you look if you're working on this patient? So would you guys look for the COPD, the GOLD guidelines?
Yes.
Right, so then that would tell you what value you're looking for. So does anyone remember? So it's less than 70% or 0.7. So this patient's FEV1 to FVC ratio, and you're looking at the actual. So his is 76%. So does that suggest that he has COPD? No, right? So, so based on this, why do you think this patient was started on inhalers?
Pneumonia?
Probably because of pneumonia, right? I mean, that's why he was hospitalized. But, you know, if the patient's not having any acute symptoms, shortness of breath or anything like that, and he doesn't have any evidence of COPD and he doesn't have asthma, would you need to continue the medication? No, so preliminarily, I would say we would stop those inhalers, right? Because anytime you give a drug that's not needed, you're increasing the risk for adverse effects, right? And so when you take albuterol, what can happen? You have an increase in heart rate, right? So tachycardia, jitteriness, all of those types of things. So besides the fact that, do any of you use inhalers? Have you gone to the pharmacy and paid a copay for your inhalers recently? You know, they're really expensive. So, you know, in and of the safety issues related to patients, you know, why have them, you know, purchase something that they don't need? So preliminarily, this patient may not need inhalers. All right. Okay.
Dr. Phillips?
And yeah.
On the spirometry report, it says that he's experiencing some dyspnea when he walks more than 100 yards.
Yes.
Oh, yeah.
Yes, I do see that. And they do often put those kind of screening symptoms on there.
I don't know.
But that is, so yes, if the patient were having symptoms, you'd want to evaluate that. But based on this spirometry, it suggests that the patient doesn't have COPD, and so you want to check to make sure that the patient has asthma, but that's something you definitely want to take a look at, and you want to verify this, because this is just something that someone wrote down when they were putting the test, so you'd want to verify it. But preliminarily, this is another reason why we're talking about this as being a preliminary plan. Does that make sense?
It does, thank you.
Okay. All right. Questions, comments, thoughts so far?
Dr. Phillips,
Yes.
I just had a question about, the EKG. Are we supposed to be able to, you know, are we supposed to know those values to be able to evaluate an EKG?
No, this is, so the main thing here is this says normal EKG. You're not, as pharmacists, you're not expected to be able to read and interpret EKGs. I mean, we do, you know, it is helpful if you can take a look at something, but that's not, as pharmacists, what we would be expected to do. But in the chart, you would have access to the actual EKG results, and they are going to have the results right there. So the main thing to take away from this is that it's normal sinus rhythm and otherwise normal EKG. And I mean, you can see the heart rate on here, which is something that we would evaluate as pharmacists, but no, we're not expecting you to evaluate these leads. Does that make sense?
Yes, thank you.
Okay. Other questions?
Can we take the question
Okay.
now?
All right, so now just kind of thinking, going down, so what are some other potential problems you see? Acetaminophen, okay, what's the issue there? Okay, so high, so it'd be 1,300 milligrams every 8 hours as needed, right? So potentially, that would be a question to find out from the patient, like how often is the patient using it? That is a PRN medication. We can look to see like when, well, it looks like you did fill it just a few days ago, you know. So yeah, that definitely would be something that we could look into and ask. What else? So one thing that I think about is this patient is a chronic user of tobacco, right? So, let's see, do we know how much he smokes?
A pack a day.
For 52 years.
He's not stopping.
1 pack per day times 52 years. So that would be a drug-related problem, right? And so you'd want to assess this patient's readiness to quit, and then if so, you'd want to help him come up with some aids for smoking cessation. And then another thing that I think about, and again, this is lower on my list, but another thing I think about is his GERD. So he's taking omeprazole 20 milligrams daily. And let's see, so that was started in 2013, and it does look like the patient is taking it. So does this patient, do we have any indication for chronic long-term use of a proton pump inhibitor? So not in the information that we have, right? We just have GERD. So we don't have Barrett's esophagus, we don't have esophagitis, some of those other more serious things. All we have is GERD. How common do you see patients take proton pump inhibitors for years and years and years? Very common, right? So what would happen if you just stopped it cold turkey? Yeah, I see. So the patient would be mad at you, right? So, because what can happen? Will their symptoms stay the same, get better, get worse if you do that? A lot of times it gets worse if you just stop the PPI. But what are the risks of chronic use of PPIs without an indication for chronic use? So there's a number of things that can happen, right? So we have recent data suggest that they're at higher risk for C. difficile, diarrhea, also B12 deficiency. They're at risk for bone fractures and kind of chronic low magnesium. So there are some reasons why patients shouldn't be on PPIs for long term, but that's not something that you're just going to go in and just, stop, go in and just stop their PPIs. Patients are going to be extremely upset with you, and they can buy it over the counter. So that would be kind of lower on the priority list because we have some other things that are more pressing. But I might start the conversation with them about what the risks are for long-term use. And if the patient did want to start, kind of consider being taken off the PPI, what would you do? How could you do it? So a lot of times you can kind of taper them off and kind of use H2 receptor antagonists and acids as needed to kind of help with their symptoms until you kind of get them off. And then there's a lot of non-pharmacologic therapy things you can do. So so that would be on my problem list, but again, that wouldn't be on the highest priority. And then as you guys kind of noted with osteoarthritis and acetaminophen, you want to see how often the patient's using it, if it's appropriate, if their pain control is good. Okay? So those are the main drug-related problems that I have. Do you guys, so what would you say, so when I fill out my sheet, what would you guys say would be kind of your number one, the highest priority problem? Okay. Okay, so gemfibrozil and atorvastatin drug interaction. Okay, so that's a significant problem. And then is there anything else that you would kind of put higher up on the list?
Hypertension.
Hypertension. Okay, so I would agree. I would say those two things are kind of the most pertinent. So if you look, so these are the things that I would kind of consider. So in terms of subjective or the information that you would collect on your patient workup form, I don't really have anything related to hypertension, okay? But with the objective, I'm going to look at the clinic blood pressures, their heart rate, and what their previous blood pressures have been. Is this kind of an aberrancy or not? And then kind of what's the drug therapy monitoring? Do I need to consider that at all? Okay? And we have the UACR, so the urinary albumin to creatinine ratio. So that's something that we would be monitoring in patients with diabetes. So I kind of have that on there as well because the patient's taking lisinopril. So my assessment then is the patient has hypertension elevated at stage 2 because it's greater than 140/90. And so then my rationale is that the blood pressure is elevated above goal. His refill history suggests he's adherent to his therapy. He probably needs additional therapy for blood pressure. And then I am looking at the guidelines. So the ACC-AHA guidelines. So that's where I get my goals for hypertension and also the comments about drug therapy. All right. So then my preliminary plan would be to increase the lisinopril to 20 milligrams every day and also kind of re-educate and reinforce on the DASH diet. And then I would follow up again like 2 weeks to monitor his blood pressure, see if that's okay, if it's now within goal, potassium, serum creatinine, and then signs and symptoms of uncontrolled blood pressure and adverse effects of the ACE inhibitor and the beta blockers. All right, so that's kind of, does that make sense, kind of how I would evaluate a patient and kind of systematically go through and look at their drug-related problems? So these are the types of things that, that we're going to be kind of looking at with each of the patients and then providing that level of kind of detail and rationale. So this explanation here that's on your form, this is really important. So when you present patients to us, we want to know why these drug-related problems are an issue, right? And kind of what the goal of therapy is. So this blood pressure is elevated above his goal of less than 140/90. These are the guidelines that we're using, and we need additional drug therapy. So, and then what your plan would be and kind of any kind of pertinent monitoring to do right away. All right. So then if you look at lipids, so there's several issues here, right? So we have the gemfibrozil dose, we have the drug interaction, and we have that the patient is not receiving high-intensity statin therapy. All right. So, so we have kind of his lipid values. His previous triglycerides were within normal limits, except the triglyceride drawn that was 293. And then his atorvastatin may not have been, and there may have been some adherence issues with this atorvastatin. All right, so the drug-related problems. So the gemfibrozil dose we talked about, he should be getting high-intensity statin therapy, and the drug interaction, and then the possible non-adherence to his atorvastatin. So those are all things that we kind of identified as drug-related problems. All right. So then, you know, as I pointed out, like the lipid guidelines, this is where I'm going to look for those recommendations and thresholds, okay? And then I'm going to look at the labs to see, you know, what was the baseline LDL, if I can determine that, and if the patient is getting the 50% lowering in LDL as we expected. And so then for the explanation, so again, so the guidelines I'm going to use to determine my goals of therapy and the assessment, and you know that the dose is wrong, why it's wrong, and then kind of the description of the drug interaction between gemfibrozil and atorvastatin, and the fact that the patient likely doesn't need any triglyceride lowering anyway. And so then for my plan, I would increase the atorvastatin dose to 40. Stop the gemfibrozil, and then rechecking the lipid panel. So the guidelines recommend between 4 and 12 weeks. And we typically do 2 to 3 months, typically. Because remember, when you start a statin or increase, you see a nadir in the effects, and that usually occurs, about 2 weeks. It dips down and then it levels out. So that's why you want to wait at least 4 weeks. Then you want to monitor the triglycerides to make sure they don't get too high, monitor for myalgias, and then monitor for adherence. So does that kind of make sense how we would go on? So then I would say that those two things are kind of the primary problem. The way this form is written out, that's why it says 1 and then secondary, but I would probably say that the dyslipidemia and the hypertension are the two main problems. And then you just kind of go on from there. We have diabetes, the cardiovascular disease that has no indication for drug therapy, and then the drugs with no indication, the GERD and the osteoarthritis. And I will post this information for you on ELC so you can see, because this is an example case, we want you guys to be able to take a look at everything. I see that EHR go as we move the case forward to the next year. I can see that some of the medication refill history kind of reset to what I did not intend. So I'll try and see if I can go back and edit a couple of those things. But I will post this for you. And then, so 2 things. We have now I'm going to have you guys go ahead and take the quiz now, so you can see like what types of questions we would ask after having gone through the patient workup. And then we also have an assignment that we want you guys to do that's due, I think on the following, I think it's due on Sunday. So we want you guys to watch a video of a PGY2 resident modeling how he would approach this patient and how he would work it up. So he'll actually fill out the patient workup form for you. And he approaches it actually in a little bit different way than we just did in class. But I think that's good because you can kind of see different ways to approach it. And then there's also a video of him modeling the patient presentation. So what we want you to do is watch those videos, and I will tell you that I sped up the first video and it was just fine. So make sure you don't speed it up too much so you can't hear him, but you can speed it up a little bit. And then we want you to write a little reflection piece on how you're going to approach the patient workup. So take a look at those things as due on Sunday again for participation points. And then we will have class again, not next week, but on Friday, and that will be another example. So this time we want you to work at the patient, use your patient monitoring form, and study it just like you would. And take the quiz. Again, we won't count the grade, but it will give you a practice of working up a patient and participating in a quiz. So if you guys can go ahead and get on ExamSoft now and take the Charlie Moore quiz, you guys can kind of see how you would do.